Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
Welcome, everyone. We are shooting this live from the NPAO conference. Welcome, Christine.
Thanks for having me, Jeff.
Having you. Oh, my God. Okay. It's the second one of the podcasts. The first one was on contraception, where I learned the term sexual debut. I have to mention that. But we got to move on. But I can't get that out of my head. So we're going to talk today about osteoporosis. Lots of controversy. Me and you wrote an article about it. Let's get into osteoporosis.
So I think in the article, there was actually a really neat quote that said, a man with one watch always knows the time. A woman or a man with two watches is often confused. And right now, we have an overabundance of guidelines to treat osteoporosis, and they don't agree, right?
At all.
At all. So I think coming from a primary care perspective, even having part of committees going and digging deep, it's super confusing. What are we doing to treat our patients? Number one, which guideline are we using? Are we actually using any of the guidelines? And how are we not missing patients? Because we know that, notoriously osteoporosis is so undertreated, yet is very prevalent and a huge cause of morbidity. And in fact, mortality if you have a hip fracture in Canada. So
all right. So let's try and clarify. Let's start from the beginning. I mean, 1 in 3 females, 1 in 5 males will suffer an osteoporosis fracture. It's a lot. Fragility fractures.
Don't forget the men.
Right.
Always forget the men.
The important stat that we should all remember is if you are a female and you fracture your hip, your chance of dying within a year is 23%. If you're a male and fracture your hip, your chance of dying is 40% within a year. This rivals mortality after an MI, yet only 20% of people who have hip fractures are actually treated. I mean, these numbers are astonishing that we're still not there.
So let's think about this. A patient goes to emergency, generally with chest pain, and he or she gets a full workup, and then there's a chain, like somebody presses the panic button, and that patient gets their assessments. I mean, maybe it's not as great as it should be, but point being, they leave with medications. They have attachment to somebody who's going to follow up with them. And I know when my patient has had a heart attack, I get this printout. This is my list of things to do. Like, it's very systemized. Maybe not, I may know that a patient has a hip fracture, but I may not know if they fell and broke their wrist until 2 years later, right? And then, oh my goodness, your bone mineral density is in the tank. And that's really crazy when you look at the stats of, and not even morbidity. So mortality, obviously, we don't want to die. But if you talk about morbidity and the concept, I think the stat is if a patient has had a hip fracture, the chance of them ending up in long-term care is 25%. The idea of living dependent on a system or needing a caregiver, patients are afraid of a few things. If you say stroke, they know what that means. They know dialysis, dementia, and being reliant on somebody else to take care of you, not being able to live independently. And it's not the death rates that scare my patients, it's that. So I think, I don't know who said it, but instead of saying a heart attack, we say you have had a bone attack,
yeah,
which is a call to action.
I mean, we can talk about screening and we will talk about bone densities and fracs, but remember, if you have a patient with a vertebral fracture or a hip fracture, they need treatment forever. They are high risk or very high risk. You don't actually need to get a bone density on them. And they're saying, what do you mean? I had a hip fracture. The doctor in the hospital told me I need a bone density. Sure, if we want to get a bone density, we can, and maybe it gives us a baseline. They need treatment a lot more than they need a bone density. So let's talk about bone densities. The Canadian guidelines talk about bone densities. This is one area I don't disagree in terms of screening. So if everyone over 70 gets a bone density, if you're over 65 and you have one risk factor, which the majority of people over 65 will have, they need a bone density. If they're over 50 and they've had two risk factors, they need a bone density. Remember, if you fractured and you're over 50, you need a bone density. But now we have FRAX, and we're basing high risk and very high risk on FRAX. FRAX is an online tool based in the United Kingdom. The interesting thing about FRAX is you can calculate fracture risk, and high is over 20%, very high is over 30%. You can calculate fracture risk without a bone density. Bone density makes FRAX more accurate, but you do not need a bone density. So think of all these northern communities we have where they don't have access to bone density. You can calculate a FRAX and treat your patient accordingly. The only problem with FRAX without a bone density is the very low risk and the very high risk aren't as accurate with FRAX without a bone density, but is a very useful tool to help us determine who we need to treat.
And just thinking one of the risk factors is a fracture, right? History of a fracture. So when a patient has a fracture debut, number one, people never acknowledge it. Like, Dr. Palmay, I fell, it was icy, I tripped, and I'm like, you would have fractured. I'm like, no, I'm tiny, but my bone density is fine. You could be swinging from the chandelier, and that's great, but that is an osteoporotic fracture. The only things that aren't are fractures to your feet, hands, and face. But that wrist that slipped on ice in the throes of Canadian winter, that we're just ending into, has to be flagged, and it's not. So when you're thinking about fracture history, people don't remember, and they don't actually correlate. And I think as physicians too, sometimes you end up in emergency with a broken wrist, and for whatever reason, we disassociate, right?
I mean, we'll talk about treatment. I think we should, and this is where the controversy comes in. So you've had a fracture, or you're deemed to be high risk, you need treatment. Every single guideline on the planet except the Canadian guidelines says, okay, first line bisphosphonates or denosumab. The Canadian guidelines have said bisphosphonates, and if there's a contraindication or they can't tolerate bisphosphonates, denosumab. And I need to address this because with all due respect to the Canadian guidelines, they took a very paternalistic attitude by saying, our concern is if we put a patient on denosumab, we're worried that they're going to stop, and if they stop, they can get in trouble, which we'll talk about. That is true, but I don't feel they should have taken that stance making the decision that our patients can't adhere to long-term denosumab. So every other guideline, including SOGC, the Americans, the Europeans, have all said bisphosphonates or denosumab first line, and we can talk about the differences that are astonishing and go from there.
Yeah. So let's start with counseling a patient on taking medications. I don't know. It's a hard, even for me, this is a hard sell. It's a conversation. People are backing off. I take my vitamin D, I take my calcium. So emphasizing that that's not treatment, that's background maintenance, just like your diabetics still have to exercise, right? Regardless of the GLP-1 that they're on, they still have to count, their carbs and stuff like that. But it's a really hard sell. And when people often hear about an injection, that also turns them down. So Jeff, you're really good with patient interactions. How do you phrase things? I think verbiage is really important.
I mean, you tell them that you're at high risk of a fracture, and I'll give them a number. Your 10-year risk of fracturing something, let's say a hip or a vertebrae, is 20%, and I explain to them significance of that. I'll talk about kyphosis. I'll show them pictures. I'll talk about mortality related to hip fracture. They understand they need to protect themselves. The problem comes in where you're talking about. So they have a pill, and the pill's an option, or they have an injection that I can give them every 6 months. I will now talk about the benefit of this injection over the pill. So we have the original trials, we have 10-year data now on denosumab, that more than 10 years, that came from Freedom. We know it decreases vertebral fractures by 70%, hip fractures by 40%. We have bisphosphonate trials, not as robust, but they work. The problem is this: bisphosphonates, we see that they plateau depending on the bisphosphonate at 3 to 5 years. You're not getting additional bone density, hence drug holidays are discussed. Denosumab, even after 10 years in Freedom, bone density continues to go up in all fairness. We have a great study now by Curtis that was published in 24 that It was a retrospective look at 500,000 patients comparing denosumab to Alendronate in this case, or Fosamax. And denosumab was 40% better at preventing major osteoporotic fractures. It's a really, really big number. And I'll have that discussion. Even before Curtis, I would talk about the 10-year data that we have with Freedom. But let's talk about the concerns that Osteoporosis Canada have, the real concerns. When you go on DMAB, denosumab, you need to be on it forever. If you stop it, real numbers, the risk of having a vertebral fracture in the first year is about 10%. That's a big number. And 30% of those can have multiple fractures. But it's not an option. When you go on insulin, we don't generally stop insulin. They can't stop DMAB, but they can convert. So if for some reason there was a problem with denosumab, we can convert them to a bisphosphonate. But I tell them, I'm starting you on this therapy because you're high risk for fracture. I believe it's the best drug I can offer you, but you cannot stop it. As opposed to a bisphosphonate, we put them on it for 3 to 5 years, and then we take a drug holiday and reassess. But remember, these are drug holidays, not drug retirements. If they're high risk or very high risk, there's no such thing as a drug holiday. So I want to start off with the best thing I can to prevent it. The other thing is, because you mentioned before generics. Generic bisphosphonates are actually a disaster. Adherence rates are low. The group in Hamilton, Adachi and his group, have studied generic bisphosphonates. Efficacy is just not there. And it's not because the drug's bad. It's a generic. It's the same. It's the fillers and the fact that these drugs, where they're dissolving in the upper esophagus, are causing problems. So if my patient doesn't want an injection, no problem. I will use branded Actonel and I write no sub, because that is one category we've had lots of problems with: generic Fosamax, generic Actonel. And so I'm passionate about saying your choice is branded Actonel, or now we have biosimilars in the denosumab world. We have Prolia. We have a biosimilar now, Jubbonti. Biosimilars are not generics. So it's a very, very important distinction. And in this case, the biosimilar is as efficacious. We have a trial. So they did a trial with Jubbonti called Rosalia. It showed it's non-inferior. It's the exact same thing. So now in Ontario, we've had to convert our patients because the government has said we've had to. And we now have a biosimilar that's a lot less expensive than Prolia. It gives them an option. It's the same drug, but they need to use it forever.
Yeah, and just some key points. So converting is really important. You want to avoid faxes. You also, if you have an EMR, you have to re-enter it because the limited use codes are a little bit different. So that's a key point. So let's talk about compliance, right? That shot every 6 months. I can tell you, during the throes of COVID, when nobody was going anywhere, I would do these runs through I have some patients in condos, retirement buildings, and people would be like throwing their arms or butts out, and I was stabbing them, right? So they don't miss. At that time, it was Prolia or Prolia, depending which emphasis you put on Lynch-Slabla. And there's a patient assistance program that thankfully has a new life with Jubbonti. So when a patient comes in, and very much like Jeff, I'm still using denosumab as my first line better option in most cases. I instill the fear of God in them. Like, you cannot miss this shot. If you're a snowbird, we've got to figure it out. If you're going to France for 6 months, you have to figure it out. I sign them up for the patient support program, and you have to re-sign them up, right? Because we have a new drug company, and Sandoz has that. I make them pre-book their appointment, and then I actually have my secretaries Tuesdays before flag to call them, right? So that there's a time period that, just in case they forget, we can deal with it. So there's a few systems that I've put in place because that fracture risk is real. But, Health Canada, or our Canadian guidelines approach maternalistic. That's like saying patients aren't going to be compliant with oral contraceptive pills. We know that. Everybody's getting an IUD, right? Like, you can't make those decisions in advance for patients and things like that.
It's funny because I don't rely on the patient support programs. Yeah. So what I do is because every single patient has a smartphone, or if they don't, their son or daughter do, I grab that smartphone or I ask one of my nurses to actually put a 6-month reminder for the rest of their life in that smartphone. And the patients thank me because every 6 months they're getting their reminder that they need their Jubbonti shot or Prolia. But I don't rely on the patient support programs. I don't mind signing them up, but I rely on
Yeah.
their smartphone
So
or
I
their
think,
daughter's smartphone or their
yeah,
son's
or
smartphone.
booking them in advance. And the other thing is pharmacists. You can direct authority to have them inject too, which is a game changer too. And has, when COVID, I call COVID the plague, when the plague part 2 comes back, we hopefully have systems in place that, patients can access their injections. My staff actually call, because they can't pronounce Jubbonti, Prolia version 2. The point being, you just have to counsel patients that it is the same. It's a molecule is a molecule. It's the same molecule. It just has a new name.
The other thing in Ontario, you guys should remember it, and we're writing letters to Health Canada now to change it, but romosozumab or Evenity, which is an anabolic, for your very high-risk patients or those with multiple fractures, very high risk over 30%, hip fracture over 4.5%, or they've had multiple vert fractures or a hip fracture. If they're a virgin patient and they've never had denosumab or bisphosphonate, they're eligible for Evenity in Ontario for free. They get a year of it. It's a huge benefit. The problem in Ontario is Ontario's deemed that if you've ever been on a bisphosphonate or denosumab, you are not eligible for the year of Romo. We're trying to change that. We have a group now that's writing to Health Canada because every clinical trial has allowed some patients that have sniffed a bisphosphonate or denosumab to be involved. But think about Romo in your very high-risk patients. It's a real game changer. And once a year, it's a year of Romo, and then you would switch them, in my role, to denosumab.
So a shout out, though, to a Canadian resource. Osteoporosis Canada is really an amazing tool. So for us, you can download Frax. You can do an enhanced Frax, lots of handouts for patients. So they have a calcium calculator, right? We're in a dairy-free, gluten-free society. A lot of how our women or even men, making sure that calcium intake is appropriate, and it kind of fills things out. There are resources for vitamin D. There's a section called Too Fit to Fracture, which I think is super cute. It talks about weight-bearing exercises and lists local exercise therapists, physiotherapists who have an interest or extra training in bone health. I always, when a person has their osteoporosis diagnosis debut, I'm going to recycle this as much as I can today. I always, send them to the website, and I actually, refer them to the calcium calculator and things like that. And some of the studies are summarized for patients. It's actually really, really fantastic. I'm proud to be Canadian when I look at that site.
The other thing I do is a bit of a cheat for Frax is I have an osteoporosis stamp that I'll use in my EMR that'll address all the questions that would be asked on Frax. And then I'll just enter the bone density in my note, in that same note. And I've created a GPT. I take a picture of the note, actually, and I ask the GPT to calculate Frax. Takes me about 3 seconds. So it's quite unbelievable.
AI, a whole conference.
Quite unbelievable.
Too. So, Jeff, what about your patient who's on whatever therapy and has a fracture? Right? What are we doing with those patients?
Okay, so we got to talk about that because that happens. What about your patient that's on Lipitor 80 and has an MI? It's not a failure of the statin. It's not a failure of denosumab. Denosumab bisphosphonates reduce fracture risk. They don't eliminate fracture risk. Honestly, if they're on denosumab and they fracture, if they can afford Evenity, they get Evenity in my world, if they have a private plan. If they're over 65, they don't have a private plan, it's a problem. But the truth is now the best I can do for my patient is get them on an anabolic if they fracture. Assume they can't afford it, they can't access this, I will continue therapy. If they're on denosumab, I'm not changing it. If they're on a bisphosphonate, I'm trying to convince them to go to the better therapy, which would be denosumab.
Okay, and just long-term, obviously.
Right, long-term. The other thing we got to talk about is drug holidays. I mean, remember the reason atypical fractures and ONJ are real and rare. We're talking 1 in 10,000, 2 in 10,000, but they're real. They happen with both bisphosphonates and denosumab. We don't have as much data with denosumab. And the recommendation is drug holiday to reduce that risk with bisphosphonates. But the reason we say that with bisphosphonates is if you look at the data, they plateau at 3 to 5 years. You're not getting any additional benefit. No drug holidays ever with denosumab. Keep that in mind. And I think ONJ and AFF, we need to talk about those risks with our patient. It's as rare as being struck by lightning. My favorite question is when the dentist will send me a note saying, your patient's on Fosamax and we want to extract the tooth. We'd like to stop the Fosamax. And my answer every time, no problem, but you're going to have to wait 27 years for it to get out of the bone to do the work. So the recommendations are you do not stop it for an extraction. If you're going to start one of these drugs and you know they have impending dental work, I'll withhold starting, but we don't stop a bisphosphonate because they're having an extraction.
It's funny, I once used the strike by lightning analogy and somebody put up their hand in their audience. They were like, I was struck by lightning. I was like, out of all things. No, I mean, the osteonecrosis of the jaw, ONJ, people read about that, and it's a real fear-mongering tactic. So my approach, too, is acknowledge that it does exist. You know, it sounds like saying like Guillain-Barré, like there are episodes, right? But what is the risk of not being treated and having a fracture and ending up in long-term care? And unfortunately, you know, people are very binary. It's one or the other, and you have to look at things contextually. But the dentist thing, I've been asked to stop denosumab when people are getting extensive surgery. I'm like, not going there, right? So acknowledge it, but the risk is really, really rare. If you speak to the dental community, everybody sort of has a story where they've seen a patient. Well, sure, right? You're dealing with jaws. There's going to be, it's a type of population that you'll see, but it's rare, and you do not generally modify therapy accordingly.
And the other pointer I've learned from an oral surgeon friend of mine is some dentists will tell their patients, oh, no, you have this horrible thing in your gums because of your denosumab and we need to stop it. And the patient is frightening. The answer always 100% of the time is if you're going to get a diagnosis of ONJ, it needs to be from an oral surgeon. It needs to be from an oral surgeon.
I didn't know that. I just learned something. Okay.
My oral surgeon friend is telling me dentists tend to overdiagnose ONJ when it's not really ONJ. So get an expert to look into that and say, because it's going to change what you're going to do with their therapies.
Okay, so I get a minute left to plummet this beautiful brain with questions. So questions that I often get, told me to take vitamin D. When am I taking it? Do you have any recommendations for formulations?
Vitamin D, lots of different formulations. I mean, for me, I like D-tabs. It's 10,000 units once a week. That's my favorite. There's other ones. There's some that are 2,000. It's a prescription. It's a daily vitamin D. Remember, vitamin D is a fat-soluble vitamin. You can overdo it, and you can get in trouble with hypercalcemia. The recommendation is 1,000 units a day. If they're lower, I'll go higher. We don't routinely check vitamin D levels. You do not need to do that. Unless you're starting therapy, I'll check it once to make sure, but routinely we do not check vitamin D levels. And I will try and convince them to take a weekly vitamin D, set a reminder on their phone. Is that what you do?
Yeah, and a big absorption tip, you have to take vitamin D with food. And it can't be a lean. So everybody takes the vitamins in the morning, right? Well, generally speaking, I mean, most people here, I suspect, are not having donuts and steaks and steak with eggs every morning. So I've had people who haven't responded, and you just take it at night. We have a bigger meal at dinner, and that has made up the difference. And if you are checking vitamin D, for anybody with a diagnosis of osteoporosis, osteopenia, there's other qualifying diagnoses as well, but that's covered, right? So you just take off the covered, and at least
if they've been diagnosed. But randomly, patients coming in saying, "I want my vitamin D level checked," the answer is no, unless they want to pay for it.
Yeah.
And the prescription D, by the way, the 2,000 unit a day one's called Luxa D. And it's
Lots of
2,000
samples.
units.
And generally speaking, I tell people, endocrinologist once told me this when I was training, that gels or liquid form have some sort of evidence. I haven't found the citation that they may be better absorbed. So for whatever reason, I recommend that. And definitely with food, just tell them to take their vitamin D. It's confusing. Thyroid without this, iron, my perimenopausal patients are on thyroid medications, iron, they need a schedule just to manage their supplements and medications. But, if you're spending money, make sure they're taking it properly.
And then before we close off, quickly, calcium. We generally recommend calcium from dietary sources, not supplements. There's 4 to 5 trials now. Some controversy, does it increase cardiovascular disease? Does it not? I don't know, because the trials say different things. But the general recommendation is get your calcium from dietary sources. And if you absolutely can't, then I'll use 500 milligrams of calcium citrate. Citrate by far is the best absorbed, but I generally do not supplement calcium. I want them to get it from diet.
The whole cottage cheese, trend is a good thing. We need a cottage cheese quantifier now for protein intake and calcium. But that's a really good point. As much calcium from diet, right? And that website with that calculator is Chef's Kiss. Is a great tool.
So thank you, everyone. Thanks for joining us.